Chronic obstructive pulmonary disease, COPD, and pulmonary rehabilitation. The article that I selected for this topic was Exploring Transitions in Care from Pulmonary Rehabilitation to Home for Persons with COPD, a descriptive qualitative study. This study by Miranda et al. Reminded me that it is a progressive, life-threatening disease, and it does affect up to 65 million people worldwide. Also, it's associated with severe, life-altering comorbidities and high mortality rates. And also, patients with COPD do become high utilizers of healthcare. And finally, COPD causes people to have optimal self-care, and they tend to suffer transition problems and when they go from one level of care to another. And indeed, they have exacerbations, relapses, emergency room visits, and readmissions. There is a cycle that people with COPD go through. It begins with feeling breathless. And when people are breathless, they avoid the activities that cause breathlessness. They become inactive, the muscles become weaker and less efficient, and they become more breathless. And this is where pulmonary rehabilitation has its impact. It improves breathlessness, and it improves self-management. It improves quality of life. So let's take a little look at what the research says. These are the benefits that I found in two of the articles about pulmonary rehabilitation. These were clinically significant results statistically. There's known safety and efficacy. There's improved capacity for exercise, including the 6-minute walk. There's reduced breathlessness and fatigue. There's improved self-management. And very few patients are excluded from qualifying from this treatment, including people who are highly debilitated and even smokers. Improved quality of life is documented, and it's been described in much of the research that I reviewed, in particular the one that I'm referring to now by Chanel and Walker, is considered one of the most highly beneficial and cost-effective treatments available. And indeed, it has been documented to shorten hospital stays. And so Garvey et al. In 2019, who are one of the researchers represented in these benefits, does predict that we need to continue looking at this treatment modality and determine what constitutes necessary and beneficial pulmonary rehab, and take the evidence seriously for the benefit and improved help to patients, also improved outcomes and decreased utilization of health services by COPD patients. This small descriptive study that I reviewed by Miranda et al., Exploring Transitions in Care from Pulmonary Rehab to Home for Persons with COPD, was quite interesting in terms of the outcomes that were documented. They looked at 10 patients. 5 were currently in a maintenance pulmonary rehab program, and 5 were new to the program. And 8 healthcare professionals participated to understand the experience of people with COPD who do these transitions from inpatient or outpatient to home, including factors that impact the transitions. There were 4 themes in terms of the results that were shown. It was documented that pulmonary rehabilitation is a safe place, it's a highly structured environment, and patients and staff alike have different views of the role of pulmonary rehabilitation. And all did view pulmonary rehabilitation as an ongoing program that they would be dependent on. And so it would be something that you would return to periodically as exacerbations would exist. The participants said that the main enablers of their transition home and maintaining capacity for self-management were social support at home, application of self-management strategies before discharge, and physical and mental health. And I do think that while it's a small study, it really did sort of bring home some of the themes and issues that we need to take forward into more highly powered studies in the future so that we can truly document the benefit and see what the costs are. During my research, I found some interesting facts that I'd just like to review briefly. Dobler et al., in a systematic review in 2020 about pulmonary rehabilitation and COPD, determined that oxygen should be titrated from 88 to 92%. And one of the big take homes I saw, both in the British and an American study, is that people just don't get this treatment. In Britain, when 68,000 referrals were audited, they determined that only 42% of the patients completed the program. And Garvey et al. Document that only 3% of Medicare recipients with COPD have been given pulmonary rehabilitation. All of the authors agree that the issues at hand are access to programs and sustainability of benefits over time. Garvey et al. Put together with the American Thoracic Society a means to bill for pulmonary rehabilitation. In fact, currently in the United States, you can bill about $52 a visit for pulmonary rehabilitation and $150 for cardiac rehabilitation. And on the hyperlink represented on this slide, there's a way to bill for the full use of services so that over 3 years, if everybody billed this way for these pulmonary rehabilitation services, Medicare would increase the reimbursement to something sustainable so that facilities could keep these programs going. Thank you for your attention, and I know I went quite long, so thank you for your patience.